Benoy, I think it's best to turn off your video for the moment.
Okay, yeah.
Okay. I was so excited to welcome everybody. I need to unmute twice. I will start again. Welcome. Welcome to Move to Learn, the Handspring webinar series for movement practitioners and manual therapists. Today is Monday, September 26th. We are thrilled to be back with you and absolutely delighted to welcome Benoy Mathew, a Master's of Science in Physical Therapy, a physiotherapist. He is one of the 3 editors of the marvelous new book, Hip and Knee Pain Disorders, Integrating Manual Therapy and Exercise. Prior to introducing Benoy, let's take a look at the slide that explains how things work. Explaining what you can expect in this webinar. This is what you can expect. This presentation features copyright material from the book, Hip and Knee Pain Disorders. Please note that this cannot be shared anywhere without permission from the publisher. The chat is on, so do say hello and tell us where you're joining from. Be prepared, because this will be an active event. Please ensure that you have space for movement to follow Benoy through some guided demonstrations. We welcome your questions and ask that you please submit these during the Q&A using the Q&A button on your screen. We will finish on the hour because Benoy has fit us in between his patient consultations. The webinar is being recorded and Handspring will share a link to it in the follow-up email. We are streaming live on YouTube, and we draw your attention to the disclaimer that this discussion is for informational and illustrative purposes only and is not meant to impart medical or therapeutic advice or instruction. Now I'll introduce Benoy, and you can bask in the gorgeous cover of Hip and Knee Pain Disorders, Integrating Manual Therapy and Exercise. Benoy Mathew is a specialist lower limb physiotherapist and advanced practitioner physiotherapist working for the National Health Service in the United Kingdom. He also works in private practice in central London. Benoy has a special interest in chronic hip and groin pathologies and management of running injuries. He is passionate about the application of research in clinical practice and has published in internationally peer-reviewed journals. Benoy is involved in regular teaching on multiple courses, both in the UK and overseas. As a matter of fact, he returned from teaching courses in Dubai and in Norway just yesterday, just in time for this webinar with you. Benoy is also the clinical lead for Shockwave Education in the UK, a trained musculoskeletal sonographer, and employs diagnostic ultrasound in his clinical practice. Benoy Mathew, welcome to Move to Learn.
Thanks so much, Elizabeth, and thanks for having me on the webinar to share our book.
Yes. Benoy, I'm so curious, what is it about your life experience that led you to this field?
I think, for the last 10 years, I've been specializing in lower limb, and that started with my own problems with my knee. I had a skiing accident and 4 major surgeries. So I was sort of rehabbing my knee for at least 8 years. And that sort of was quite frustrating, but I guess that's made me a better therapist. And I was fortunate to work with other leading researchers and clinicians in the area, and that sort of spiked my interest in lower limb, especially around the hip region. So, and we wanted something which sort of highlights the new developments in the hip and knee region, which covers all the latest development, and most important, being a practical side as well. So, so when I had the opportunity to be involved with other esteemed colleagues on this book, it was an opportunity I couldn't really refuse, although it took quite a bit of time. I'm really pleased with the end results, and the feedback has been amazing, and really humbled to have played a part in this.
How did you meet your co-editors, and how did the idea for the book come together with the 3 of you?
Yeah, I think the brainchild of the book was Cesar Penez, who's a full professor from Madrid. He's prolific, and he's done a similar book on the shoulder with Jeremy Lewis. So it was felt there was a need for something similar in hip and knee, because there's been a lot of growth in this area, both from the surgical as well as non-surgical side. And we felt, although there have been good books on various aspects like manual therapy, exercise, assessment, we want something which could be quite simple, something simple, but also which could stand on its own for within clinic. So you got a patient with a meniscal problem or patellofemoral pain or with hip impingement, you could just go into that particular section and then look into that. And we also wanted to involve new technologies like ultrasound, which is gaining popular with many therapists across the world. So we felt we need something like that for the clinic. And so we're fortunate to have worked with more than 40 plus contributors from across the world, from US, UK, Europe, Australia, New Zealand, and bring together this sort of unique book, which looks at more like a reference slash a practical handbook for people who are dealing with most common hip and knee pathologies in a typical musculoskeletal setup as well. So that's sort of how it come in. So we have three editors here, myself, Caesar, and we also had Carol Courtney from the States give us a lot of input from her experience with knee and other pathologies as well. So it's I like to emphasize it's a teamwork, and a book of this magnitude can't be achieved by one or two persons. There's a lot of people involved, and also like to thank Handspring for their effort with the initial design and layout and all the helps they have done. So it's a teamwork, and I'm glad I could be involved in that.
Absolutely. How does your experience as an educator, as a global educator in this field, how has that informed you and led you to understand how to make a book which is most beneficial for the person in the room with the patient, with the client?
Yeah, so I'm a full-time clinician. So, although I teach quite extensively, I still see patients at least 4 times a week, and I have a full list. So for me, I think having that clinical exposure on a daily basis for them for the last 24, 25 years has made me real on what obviously the research is really important. But when you're having a patient in front of you, you want to have a framework, a sort of, I wouldn't call it a recipe, but a sort of system in place where you could go systematically and have a look. So that's what we have done in the book, is having this 3 section where we cover sort of initial pathologies, look into all the multimodal options. And one of the unique feature of the book is we has also included patient stories. So the patient is the center, of a book, and we wanted to highlight their experience. So just like I struggled with my knee for about 7 or 8 years, so we want therapists to understand the struggles and frustrations they go through. So we have about 3 or 4 patient stories which highlights their sort of plight going through that. So that sort of experience from both the patient made it to narrow down. So we always go back to the central question: is this clinically relevant? Is it something they can apply? So we didn't want it just like a theoretical update. There are some very good books on that, but we want something which could be applied right in front. And we just decided to put into each different pathologies, covering all the common pathologies of the hip and knees, and also evolving areas. For example, I've not seen any good other overview on emerging condition like hip dysplasia. So we're lucky to have a segment on how to manage that as well. So we try to keep it as up to date as possible and relevant for the clinician when they treat the patients.
Well, let's dive right in. This is a massive book that took how many years to pull it together?
Just 3 years in all, and thousands of hours of all the people involved, and so I've lost track of all that time. So it's a bit of a blur looking back, but the joy you get when you have that in your hand is worth it. So definitely, as I mentioned, clearly it was a massive team effort from all the editors who made a lot of sacrifice from time away from their family, spending countless weekends away, and going through the script and revisions and multiple revisions and diagrams and photo shoot. So this considerable book of this magnitude, you can't really put in words the number of hours you've gone through, but hopefully from the feedback I'm getting, it seems it's worth it.
Outstanding. I can't wait. Please take us through the slides you've selected.
Yeah. So what I thought was to start is to pick up a few key areas in which I was personally involved. So I'm going to pick up as excerpts from certain key elements of the book. So the first one I picked up was looking at the examination. I think for me, a good examination, is the keystone of any diagnostic process. So we have laid out all the key elements of hip and knee examination. For the purpose of today, I'm going to focus on just the hip alone today. So hip and groin is something which I feel many healthcare practitioners in musculoskeletal field really struggle. So they think, is it from the hip? Is it osteoarthritis? Is it impingement? Is it dysplasia? Is it soft tissue? Is it coming from the back? So we wanted something which is quite simple for people to use in the clinic. So if somebody comes in with chronic hip and groin pain, what sort of some simple tools and diagnostic tips can we use to sort of help us to identify? One is, if the symptoms is more than 3 months, it generally means it's more likely to be intra-articular, but also asking them the source of pain. So these are all pictures from the book where we go through different diagnostic criteria. So these are the signs usually used by patients who have intra-articular hip pathologies, such as hip impingement or hip dysplasia. So people will come with the C sign, triangulation sign, deep pointer sign. So they can't really pinpoint. So if you ask them to use a finger and pinpoint like an exact location of pain, they will not be able to show, for example, with adductor pain or other regions as well. So they will say like the pain is quite like deep, it fluctuates, it moves around, it's poorly felt in a particular location. So this sort of presentation from a patient should make you highlight that this could be potentially coming from the hip joint. Obviously, the history we'll go through. In the book, we go through what are the key questions. There are about 30 questions which you need to ask based on a history. So, things like childhood hip diseases, any accidents, screening for red flags. So there's quite a few things there. But this is sort of the key objective to look at. Ask them to localize the pain. And if they have this sort of signs, it sort of indicates that could be intra-articular. And another simple test, which I'll be able to, show, is the foot progression ankle walking test. So it's a simple test where you ask the patient to sort of rotate the foot 15 degrees internally and then walk in and do the opposite. So people with intra-articular problem like hip OA or impingement are more likely to have pain with the picture in A than in picture B, whereas somebody with hypermobility with the dysplasia will more likely to have pain in B. So obviously with hip or knee, you never get a complete diagnosis or anything with just one test. It's always has to be used along with the subjective and as part of a diagnostic cluster. But these are some simple tests you could use in a clinic. So one is location of the pain. Is it deep, vague, or non-specific? And how is the response to the pain with a simple test? So that sort of gives you an idea whether the pain is coming from the hip or outside the hip. So generally, hip pain can be put into 3 categories. One coming from the hip joint itself, second coming from outside the soft tissue, extra-articular. Number 3, referred from other sources like the back, SIJ, or even non-musculoskeletal disorders like gynecological disorders and other things like that. And simple look at range of motion is something we can check, whether it's a physio, osteo, sports therapist, a yoga teacher, looking at range of motion is really important because that sort of gives you an idea of what morphology, what type of hips they might have. So generally, if you have restricted in internal rotation, that could be, either they're a retroverted profile or it could be signs of CAM morphology, which I'll go through shortly, and also looking at external rotation. So normally, in most patients, the external rotation is generally more than the internal rotation, and also looking for the pain response as well. So range of motion testing is really an important element of assessment of the hip. And you would check in multiple positions. You might check them in sitting, in supine and prone, and see whether that sort of change of position varies that. So those are some of the key tests to look at. Now, bear in mind that there is nothing called a normal hip. There's so much variation around the hip and pelvis than any other parts of the human bony system, and also big difference between male and female. So if you look at the neck shaft angle, so some will have a short neck called the coxa. The normal angle is between 120 to 135 degrees. And this a bit more is called the coxa valga. And your rotation of how the femur rotates, you can have anteversion or retroversion, and also the way the acetabulum is sort of oriented as well. So we can't just label people into this sort of saying this is the perfect way to squat or the perfect way to sort of lunge, because there's so much variation, and these are all normal variations of the human body. So that's why good history, looking at the objective test, looking at the range of motion, and in many cases you might have to look at their some cases you might have a look at their X-ray views as well, to look at whether what type of orientation they have. And this is really important to know, because your management might change and your exercise prescription might be different based on their available range of motion they have. So somebody who has a sort of anti-verted hip, who likes interrotation, you might not give them exercise like the sumo squat, which pushes them into external rotation and load them. So it's respecting the human body according to the variation it has, and trying to personalize the therapy rather than fighting the body and the shape we are born with. So that's something which I'm quite passionate about, is understanding that huge variation we have, both from a gender point of view as well as racial point of view, because some ethnic races are more likely to develop dysplasia, and some, because of the childhood sort of sporting activity, they might have a different profile. So it's having that big picture. So let's go through some sort of key points. So let me bring the video to a different program. Let me stop the screen share. And okay, so we got a program here. So going through the test again. So the first one is so looking at the sign here. So patients who come with sort of deep sort of pain, they won't be able to specify one location. They will say their pain is sort of deep here. So they will sort of hold it around the greater trochanter, called it the C sign, or they might use this sort of sign where they lean in, and sort of they say it moves around. They might feel like a muscle tightness, but it doesn't go away. So sometimes it can go into the groin or into the thigh. It's very different from other patients where the people say the pain is just over here on the greater trochanter, which is more likely to be from your greater trochanteric pain syndrome, or somebody who says my pain is in my adductors, which is sort of linked with sporting activities like football, rotation sport, or somebody who comes with proximal hamstring tendon. So with this sort of condition, it's more specific. So if a patient comes with more like a deep, achy pain, non-specific, and they're saying it's sort of, they can't really localize, and they're doing all sort of weird things like this, like that, it's sort of highly suggestive that it could be coming from the hip joint. The second thing, to remember is, which we say is a simple, let me see whether the foot position. So looking at the foot position here, so given when you're walking, ask them to stand normally and ask them to squat in the normal pattern. If you're somebody with retroverted profile, you naturally will like to squat in this open posture. Somebody who is sort of antiverted will prefer a narrow stand or even like this. So asking them to squat in what they feel natural will give you an idea what sort of shape the hip is. And asking them to twist the foot in like 15 degrees and making them walk, and ask them, does that feel natural to you, or does it cause any pinching pain? And doing the opposite as well, sort of going this way, whether that makes any difference. So these are simple things, regardless of whether you're in a class or one-to-one. It's something which you can start looking at a patient, and gives you a bit of an idea of what sort of
Benoy, camera angle has changed.
Okay, yeah. So let me. What sort of hips they are, and if you can look at the picture here, so this is sort of normal hip, which is not always present. So some people will have a shorter angle, longer angle. Some will be rotated in and out. So it's understanding those variations which should have predispose. And this sort of simple test, which we go through. Let me change that. Which you go through in the book, sort of gives you some simple tools, which gives you an idea of where the pain is coming from. So one of the biggest problems people have with hip and groin is knowing where the pain is. So that's why we spend a lot of time on the subjective and some simple tests you can use in a clinic to help you sort of identify the source of pain. because for me, the right diagnosis is 50% of the treatment. So getting it right in the initial few sessions is important so as to guide us moving forward what will be to plan their exercise or manual therapy from them. So that sort of is the gist from chapter 12, looking into the clinical examination of the hip and knee. Over to you, Elizabeth.
Thank you so much, Benoy. Having worked for so many years or decades now with dancers, I'm accustomed to the dancers that are, of course, they are selected for success in their field because yes, because
it's a selection. People who have that sort of profile, they go into dancing or yoga teachers or something like that. So you find a high incidence of those sort of profile in those performing arts. But it's again working with that limits and not pushing it beyond what's acceptable to the body and not predisposing them to late in life problems like osteoarthritis. So I think if we understand the variation rather than stereotype people in certain boxes, whether you are a yoga teacher or a Pilates teacher, it's knowing that we have different shapes. Like you have a normal variation, you have anteversion, retroversion, you have a lax hip, then you have hypermobility. So it's sort of screening. If you got a student or somebody struggling with certain postures, it's something you can do sort of this simple test and help you to identify where they're comfortable, and you can modify your exercise based on what they feel natural for the hip. And if you feel any pinching pain, anything stabbing, sharp, then you know that your joint is not happy and you might have to modify that rather than pushing through it.
Are there particular exercises or particular exercise categories that you go to when you notice that a client has chosen an activity that is not optimal for their structure?
Yeah, so I think what we find is I'm a big fan of yoga and Pilates. So, but like anything, any form of exercise can be done badly, So it's not reflecting on any particular form. So we must encourage activity, but the certain postures, especially new, like where there's extreme twisting, some of the rotational asanas where they sort of go into deep flexion and end range rotation, for somebody who predisposed, for example, with a cam or impingement, they'll feel like a deep ache, like a block. So nothing wrong with that, but it's just pushing beyond that. So if you feel like a bony block, if you feel like a pinching, maybe you've reached your limit of your bony, morphology where you can't really go beyond that. And the same thing is also with stretching. So if you have like a dysplastic, really flexible hip, which is great for dancing, but if you stretch it excessively into end range extension or external rotation for very long periods of time, that sort of could be a problem. And many of those might not supplement with good strengthening. So again, it's a yin and yang, stretching and strengthening, they go together. So it's having the balance between the both elements. Because sometimes when you love a sport or love an activity, you do more of it, but you don't have the opposite element to keep that in check. So the bit of cross training, suppose you're doing 6 days Pilates, 6 days yoga, or 6 days running, that itself for me makes me wonder, it's like eating food, you need carbohydrates, you need fats, you need proteins. One is not better than the other. You need the three. So same thing, you need the strength, flexibility element there and the cardio. So it's putting that all together with our patients.
I know that one of the chapters in the book focuses on exercise prescription or guidance. Yeah. And is that what's coming up next?
So I thought we'll go next to the foot and ankle, because although it's a book on hip and knee, we can't, ignore the foot. Let's go through that in a second, and then sort of it's got stuck there. Can you see my screen, or is it sort of?
Not the slides yet.
Not like so. Let me kind of show click. So let me go back to. Yeah. I'm going to share the screen and then.
There we go.
Yeah. So next one is we're looking at is the foot and ankle. So we had a bit of a debate among the editors whether this is important, and Caesar was quite clear that it should be there, and I definitely agree with him there, because the foot and ankle is something we have to consider with anyone coming with hip and knee pain, because we know how important the mobility of the ankle is for force distribution, and also linked with certain conditions like patellar tendon problems, chronic knee pain like patellofemoral pain, and also when we're teaching them exercises like plyometrics. So I think the tight restriction of your ankle has been linked as a risk factor for multiple knee injuries. So sort of when we talk about patellar tendinopathy, even with patellofemoral pain, when you have restriction, it increases your contact forces when you land and jump, and also help, you're more likely to move into valgus. So if somebody goes into valgus like this, people jump in and say, oh, it's weak hip, but the culprit might be actually the ankle. So assessing somebody's ankle mobility is something I do first when somebody comes with hip and knee pain. And we can do that in a variety of ways, which I'll go through using simple tape, or also looking at things like apps, which I'll show you in a second. So these are some simple tools which we can use to have that sort of looking at their range of motion. And so one method is using this inclinometer, which I'll go through in a second, and so looking into the knee to the wall test. So the normal range is between 9 to 14 centimeters, and the difference between side to side should be not more than 2 centimeters. And when we check, so most modern phones have this sort of inclinometer, which I'll show you. It should be around 40 degrees. And if you're restriction, then you need further assessment to know whether it's coming from tight calf or from the joint, and some of the exercises which you can help you to to improve that. So that's something to bear in mind, is the mobility of the ankle, the big toe, the control, and also the balance. You might check into some star exertion test before we start to push the exercises with hip and knee. And rehabilitation will involve some of the key muscles of the foot. So we're really fortunate for this chapter. We had Fraser McKinney, who is the rehab, the chief rehab physio at the Southampton Football Club. So his special expertise, this is chapter 14. So his expertise is on foot and ankle, and he teaches internationally. So, and it is quite tough to get him because he's such a busy schedule, and fortunately we were to pin him down for this, and he's done a tremendous job going through because foot mechanics is highly complex, but he's made that in a very simplified way for us to understand. And whenever I'm in doubt, I read the chapter on foot and ankle just to get my head around the complexities of the foot and ankle. So, and he also gives us a lot of rehabilitation ideas. So on isometric holding in the tibialis, and also some of various strengthening exercises as well. Tip post really important for the medial arch and supporting. And there's also mention on the foot core system, which is sort of a new area, looking at the function of the foot muscles, the intrinsic foot muscles. So historically, we thought those was important for the arch. Now we know that they are really important for improving the stiffness of the forefoot, which is so important for the propulsion force of the calf complex. So when you are rehabilitating anyone with a calf strengthening protocol, it makes sense to include strengthening of the foot intrinsic muscle, because those muscles make it like a stiff lever, and improves the force output of the calf complex as well. So we do cover on that. And big thanks to Fraser for putting a lot of work on this sort of complex area, but also simplifying that. A quick look, which I might show you, which is something which I use in clinic. Let me bring the is looking into a simple way to check your range of motion. So I've got what I've got here is, I'll show it on my phone. The app. So all modern phones have an app. I'll just open it up, and then I'll show you how to do that in real time. So this is called clinical, inclinom. Let me see, we get it. So this is sort of, which will give you an idea of how much to check their ankle range of motion of the dorsiflexion. So it's iPhone, I think it comes as standard. You also get a lot of free apps on this on Android. So you ask the patient to take a lunge. So I'm going to get the camera set up here. So you can look at that sort of view here. So I'm taking a lunge and I got around, let me bring it up. So I've got a bit of around 53. So one might not see that. So that sort of is a simple method to check your ankle flexibility, which can be done. Most of us have a smartphone nowadays, so that is something which can be sort of done in your clinic. So it's coming and looking into the ankle mobility, looking at the balance, and also looking at the foot intrinsic muscle. So the app is called it's called let me find the name. It's called Clinometer. It's called Clinometer. So I'm typing it here. So that's something. Again, there are so many apps which do that for you. So they're quite reliable, and there's something which you can easily incorporate that in your clinic. So anytime I see a patient with knee and hip pain, checking their ankle mobility is something which I routinely do to help them sort of to understand the foot mechanics, which influences the forces going through your whole lower limb. Thank you, Elizabeth.
Yes, I will. Searching for my cursor. Yes. Benoy, how do you integrate your exercise prescription for an independent home practice? How do you integrate that with your manual therapy and your sonography, et cetera, in the clinic?
Yeah. So I think the last part, which maybe I can go through, would be looking into, let me pick up a condition which we cover in chapter 5 and chapter 6 is on hip impingement. One of my favorite topics which I teach is because there's sort of a growing evidence. So hip impingement is much more common than we think. It's sort of leading cause of hip and groin pain in people below the age of 45, especially in the active type. So the diagnosis is sort of made by a combination of pain during end range flexion, rotation, and they might also have changes on the X-ray, which we'll go through. So the most, so commonly known types is the CAM, where you get a bit of extra growth on the atrolateral aspect of the hip. And then you also have a pincer type, which is a protrusion of the acetabulum. Most common type is actually the mixed type, where you have a little bit of CAM and a little bit of the pincer type. So you get a bit of a both here. So, and this is quite a common variation which we see in, so if you take 100 people without hip and groin pain, anywhere from 20 to 30 to 40% will have that based on their activity levels and the age. So this is something which we normally see, but in some people it becomes symptomatic and it can cause a lot of, it can affect their day-to-day life pain, and they struggle with their ADLs. So this is sort of, this is again from the book, which gives you a snapshot of what sort of people in your clinic would you suspect with hip impingement or FAS syndrome. So generally they're sort of between 18 to 40. They're quite active. They're involved in sporting activities, and the pain is a bit of a more gradual onset. It doesn't start generally in one day. It's more like a stiffness initially, and then they start getting that sort of deep achy pain, like the C sign, and all the signs which I mentioned before. They might have like clicking, catching, popping sound, and they might have pain during deep squatting, twisting, and they might struggle with certain postures in yoga, or they might struggle with spinning or with the CrossFit, some of those sort of activities. And when you assess the range of motion, they might have pain or decreased range in end range, like hip flexion and internal rotation. And if you use something like a handle dynamometer, you might find weakness in some of the key hip muscles like the hip abductors and adductors, and also reduced strength of the trunk and hip. And so this sort of is your typical presentation, which you see in clinic with somebody with hip impingement syndrome. So the management, which we cover on a book, at this point of time, we don't have like a gold standard of a randomized controls trial saying that this is the best way of managing, but we have given a framework, looked at the current evidence, and we've given you the selection of all the common methods used, from manual therapy to soft tissue to dry needling, and a big emphasis on, and also a big emphasis on rehabilitation, which is the cornerstone. So for me, the main element is the education, load management, as well as exercise. In many cases, which is highlighted in chapter, let me bring in chapter 16. So the chapter 16 is joint-based intervention. We're lucky to have Thomas Mitchell as a leading tutor in the UK. He teaches the Mulligan method internationally, and he's also got expertise in wrist and hand as well. So he covered the chapter on looking into some of the techniques you can use in a clinic for helping somebody in pain with hip, especially intra-articular pathology. So here he demonstrates the prone PA mobilization of the hip and in a different position. And he also uses a lot of these bands, which sort of can be done in more, functional weight-bearing position. So he's using a 4-point partial weight-bearing lateral glide in hip flexion, and then he's doing one in supine. So this is sort of methods which manual-therapists across the world use, but he gives them theoretical basis. There's plenty of pictures, and he goes through them systematically. So you got a lot of option to choose from some of the appropriate manual techniques you can use, which might be relevant for somebody who is struggling with pain and could be part of the initial management of somebody with hip impingement syndrome. And the rehabilitation element. So we go through in different phases: the early stage, mid stage, late phase. So this is some of the exercises, quite straightforward exercises which you could sort of incorporate the patient at sort of from home. So here we got starting from a double leg bridge to single leg bridge, then some form of hip abduction strengthening, and then in the plank variations, there's a plank knee extension. Actually, the leg underneath the hip flexor works harder. So that is one of a good tests to look at lumbar-pelvic strength and stabilization. And then the split squat is a good option as well. And some low-level adductor strengthening programs might be something which you can incorporate. And then in the book, we go through the next phase, the mid phase, the late phase. And we're fortunate to have Holly Doyle, who is an expert in hip dysplasia from Stanmore, London, where she's done the entire section along with Mike O'Brien, who's doing his PhD from La Trobe. They covered the section on hip dysplasia. So the systematic approach on how to work on these patients, which is generally not published from what I've seen in a book. So it goes us through the various methods, like from proprioception exercises, stabilization exercises, and some how things are different in this group rather than from somebody with hip impingement. So if you're dealing with dancers, the hypermobile population, you're more likely to deal with hip dysplasia rather than hip impingement. So again, there was a big request from a lot of physios and osteos on looking into management of hip dysplasia. So we have covered extensively, and big thanks to Holly and Mike O'Brien for covering that in detail. And they're really passionate about that topic. We'll be seeing some good papers coming from Mike in the coming years on management of hip dysplasia as well. So that's something which we cover in detail. And that is, let me look up, that's chapter 5, I think. Yeah, looking at FA syndrome, hip dysplasia, hip instability. We try to put all the key evidence in one chapter. And looking into sort of the rehab options, we sort of, a lot of things we can use, like which is used by Thomas. He uses some of this sort of Mulligan concept belts, the self belts, and some of them you can do at home with self traction to help you with your pain relief and improving the mobility as well. And also, sort of some simple bands, which you can sort of incorporate with hip strengthening. So I'll show a couple of simple exercises which sort of I use constantly, with the repeated, which is sort of prescribed with this sort of patients, which I'm sure you'll be aware of that. So let me move the camera here. So one of my two favorites is what is called the X walk. So we sort of moving out. So the position of the band, if you want it more on the abductors, you put it on above the ankle. If you want it more on your external rotators, you put the band on your midfoot. And if you want to correct the valgus, you put it on the top of the knee. So a quite simple exercise I'd start with is something called X walks, where you go zigzag and walking back and then walking front. So that's something it's going to really strengthen the hips. And also the classical, when we look at that sort of crab walks, you want to have that slight forward lean in the athletic position. And then if you want to emphasize a little bit on the calf, I'll ask them to go a little bit on the toes, and that will really strengthen, help you to get that calf working along when you're doing the band walks. So I usually ask them to work on the toes, and that I find a bit more useful. So there are quite a few. Let me change. So there's quite a few exercises which we have gone through in the book. So most of them are something which you can incorporate at home with bands, slings, gliding discs, which are really good for working on hip mobility, and also using the belts for hip distraction. So this is something which can be incorporated along with rehabilitation and help in that optimal rehab of patients with intra-articular pathologies like impingement, hip dysplasia, and also early osteoarthritis. Thank you. Over to you, Elizabeth.
Yes. Benoy, what comments do you have regarding the most recent research you've incorporated in the book regarding pain neuroscience of the hip?
Yeah. So I think let me bring it up. Chronic pain. So there's been a lot of so that is chapter 21 on the book has been done by Cesar and Emilio Louis, who's an expert in chronic pain. And so there's been ongoing debate on this hands-on and hands-off intervention and in lower limb. So there's a big emphasis on pain neuroscience education, where we call it the treating the brain and hip and knee syndromes. And Emilio has written that with Thomas Longbottom, where he goes through the neuromatrix and also and how to sort of explain without causing catastrophisation or fear in patients. So he goes through the language we use and also how to sort of reason out with them. So a lot of patients with chronic hip pain, especially I find with impingement or dysplasia, have big effect on their day-to-day life, and it affects their emotions. And also they struggle with knowing that I'm going to live the rest of their life as well. So we felt that was an important component which has to be addressed. So it's just not about, giving exercises or traction or with your rehab base. So it's treating the person as a whole. And that chapter is best read if you've read the patient stories. So the patient stories, we start the book with the patient stories, because that is something, really important to know from a patient's own experience of how they go through that. Because we emphasize in the book, like pain is sort of the intersection between biology and culture. I love that line, so it's a very unique experience based on your cultural percepts and also the biology of pain as well. So we have to address both elements. So the book is sort of definitely within that biopsychosocial model. It's just not a pure collection of techniques or rehab ideas, although those are important, but it's delivered by the clinician in a biopsychosocial model, which is really important so that patients feel like they're heard. And that's why reading the stories will give you an idea of what sort of things trouble these patients, and they can sort of plan this going forward.
Benoy, when you accept a new person, a new patient into your practice, do you have an expected timeline or structure of how frequently do you meet with the patient? How frequently do they do their home exercises? And what sort of progression are you looking for?
So we know from the research is most people's compliance in exercise drops down usually anywhere between 2 to 4 weeks. So if you give big gaps, that's always a concern that they might not do the exercise or they might not feel as much motivated. So in some cases, you might have to see them quite a bit. So there's been studies on gluteal tendinopathy, which has been published from the LEAP trial, where they had an average of about 14 sessions spread out over 3 months. So that might be appropriate for that condition. So obviously it depends on the age and the pathology they have and the commitment. Now, the good thing, one of the good things which came from all the from what we had during the COVID was the use of Zoom and other technologies for follow-ups. So I use that quite a bit. So a lot of screening and review check can be done online. So I do that with a few of my international patients, where they come down, they see me once or twice, and then they sort of have review appointments with them. So I think the future is going to be a blend of online as well as face-to-face. But definitely with the hip and groin, I prefer to see them face-to-face in the initial appointment. And if they're very irritable, I might see them twice a week, and then gradually wean them off to once in 2 weeks or 1 3 weeks. But it depends on the setting. So, the setting I do in private practice is quite different from NHS. So those sort of setting things are really important, and you're constrained by the system. So, but generally giving big gaps more than 3-4 weeks will potentially lead to poor adherence and compliance. And that's been shown by literature as well. So I try not to give big gaps.
Thank you. What recommendations do you have regarding how movement practitioners can work best or optimally with the manual physio who's guiding the treatment?
Yeah, I think I'm a big believer of teamwork. I work with some of the leading sports medicine consultant, hip and knee surgeons, radiologists. With a lot of my acute phase, I worked with some movement-based therapists because it's going to be a combination of things. So because many of these conditions are complex and they'll need a sort of multidisciplinary approach. So one of the things when I liaise with movement-based therapists, suppose I'm referring for somebody for a Pilates for the stage 1 of rehab, is making it very clear on the areas of things to avoid. So I would say, please avoid end range flexion and internal rotation, not to cause pinching, and not to do any straight leg work. So I think it's making the clarity and being very clear on the most things not to do. The things not to do is as important, if not more important, than the exercise itself. So what we find from my experience with hip patients are they really stir up things. Like if you stir up a hip and it becomes really sore, it can take anywhere from 2 weeks. In some cases, it can take up to 3 months. And we don't want that with our patients. So it's not irritating the hip, but also getting them stronger and more stable. So they're having an open communication. And that's why, having shadowing. So if you get the opportunity to go and spend time, I've shadowed Pilates teachers, yoga teachers, strength and conditioning coaches. I've sat in radiology meetings. So spending time with other professionals, even if it's just for a couple of hours, gives us an idea of what they're thinking, how they manage things. And most of these patients will need an input from multiple professionals. It can't just be physio. It can't just be a surgeon. It can't just be a movement therapist. So it'll need and they'll also need some strength and conditioning at one stage. So it's going to be a teamwork. And the more we sort of link up and make it very sort of clear. So I think having the clarity on communication. So whenever I make a referral, I make it clear the things not to do for that condition. For somebody with a dysplastic hip, I might say, please avoid end range extension and external rotation. So I'll say that sort of aggressive stretching for somebody during the rehabilitation. Stretching is not bad at all. So stretching is important and can be linked with performance. But if somebody is coming to me with pain and they're in the rehabilitation phase, then during the time, I might put some clear guidelines and some sort of parameters, and then later that can be removed as well. So we have to be quite clear where these sort of things are, with the patient. So, and another thing is if you're not clear with each other, that creates confusion with the patient. So I can't be saying one thing and then he or she goes to a yoga teacher or Pilates or a soft tissue therapy or somebody else, and they get conflicting images. That doesn't help anyone. So I think we're having the clarity. So whenever I refer to anyone, I make sure that I call them up or email them, I hand over my patients and say, this is what I've done, and this is what I would suggest not to do for that period of time. and then we can review as well. So it's having the clarity, and that same thing happens with surgeons. When the surgeons send me patients, they're very clear is for that 6 weeks, don't do this, don't run for 4 months. So I respect, because when somebody has done the surgery, they know best from a surgical point of view, and I have to respect the tissue healing. So when I get a patient with surgery, the first thing I'll ask from the surgeon is, when can they run, or when they can go off the bike, or when they can swim. So I get this key information from the surgeon, and then I can work with my rehabilitation as well. So working cross-referral, whether it's a movement therapist, a surgical referral, or strength and conditioning, same thing with strength and conditioning. So if I'm going to send a patient to a strength and conditioning coach, I will say, avoid deep squats, maybe use alternatives like hip thrusters, or a safety bar squat, or a trap bar deadlift. So I'm giving them options. So I think one thing which I've learned over the years is, it's easy to say to patients, don't do this, but we need to give them alternatives. So rather than say, don't do this, you need to tell them what can they do instead. So rather, if I say to a patient, don't squat, that's not going to help them. So I can say, maybe do this instead for 3 months, and then we can go back, or 6 weeks. So I always give them other variations, like, okay, let's try the goblet squat, let's try the hip thrusters, those sort of variations, and patients will comply. If you totally take the things they enjoy, then they're not likely to involve in rehabilitation. So that's quite important, that patients are given choices whenever we take anything. When you say to a runner, don't run for 2 weeks, what can they do instead? Deep water running, or something on the cross trainer. So it's giving those sort of alternatives, which makes the process more compliant. So those are my key points working with the MDT approach.
Thank you for the generosity with that thorough answer. I can understand now why the book took only 3 years and is still so thorough, because you have all of this information at the forefront of your cortex, and one only needs to ask the question, and there you go.
Yeah, but as I said, it's sometimes you don't need so much of depth. That's why the book gives you where you can just dip in. So if you feel like you just need to do a little bit for a patient, you can just dip in, have a bit of read a few pages. But if you just want to go in depth, then we cover it as well. Because, for example, you might not see some hip patients like I see, like hip dysplasia. You might just see more of knee patients, or seeing more of tendon problems. So we appreciate that there's a huge variety of patients seen. Some are very specialist areas. Some are more common, like knee osteoarthritis, patellofemoral pain, greater trochanteric pain syndrome. So these are quite common conditions, which we have gone in detail, which you're more likely to see. But we also covered specialist topics as well, like the ACL, PCL, those sort of conditions, proximal hamstrings. So we sort of covered the most common and not so common cases, which can be seen by, therapists as well. So hopefully we try to keep it as comprehensive, but we didn't want to make it bigger than it is, because then otherwise you won't be able to carry it. I think it's already a bit heavy. So, if it becomes too heavy, then you're less likely to read it as well. So I think we found that sweet spot where it's sort of, still accessible, but not too big to put you off from accessing it.
Absolutely. It does require its own bolster to hold it up.
yeah, definitely. I think when I got my the first edited copy of 4 or 5 books, I got a call from my partner and said, I hurt my foot, and she said, I dropped this box for you, and it was actually the 5 books. She dropped it on my leg, and luckily nothing untoward happened. So it's quite heavy, especially when you're carrying 3, 4 of the books of those sort. But generally, it's quite user friendly. And we have tried to make it, as I said clearly before, you don't have to start reading from the first. We try to keep it separate on its own. So if you just want to look on an ultrasound, you can just go into the ultrasound. Just want to look at the foot, you can just look at the foot. So people might dip in and out based on the needs and the patients going in, and that will be useful for them based on the cases they see.
Benoy, we have someone in the chat who's already eager to accept your invitation. She said it would be great if you were happy to come and shadow you. And so Joe Strutt is wondering how to find you in in
Yeah,
central London.
I'm central London. So I work in Life Plus Clinics, which is in about 3 to 4 minutes away from Bond Street. I also work with a group called R&D Physio. So I think, if you Google me, what also is we got links to I'll put my link, which has links to all my course. I'll just put one single link in the chat, and then that should cover that. Yeah, I can do that in a second. Let me bring it up. So this should give you, this is function. Yeah, so that sort of is a tree link, which gives me all link of where I work and all the other information, what I'm up to, my courses and everything like that.
And Joe Strutt also has a further question. Can you advise on kneeling in knee replacements? Some consultants say that you can't.
Yeah, so I think this is one thing, when you work with, consulting, especially, I've worked with 340 consultants while I was working in Croydon. So I used to be involved with knee replacement. So it depends on certain types. One, if it's like a uni compartment where you just replace one compartment, they generally are a bit more easier to rehab. They recover really well. And other things is sometimes one of the things which we know from the research is kneeling ability is consistently the most poorest patient-related outcome after knee replacement. So that is something. So it's around 60 to 80% of patients report difficulty kneeling after knee replacement or inability to kneel. So I think it's discussing with the consultant is that are they concerned if they're talking about a particular timelines or they a particular sort of implant. Another big element is the BMI. So I have consultants who will not allow kneeling at a particular BMI limit because they're concerned about loosening and things like that. So I think when a consultant says not to kneel or not to run, it's knowing what's the criteria. Sometimes there are some surgical criteria, for example, like looking at hip or knee replacement, what are the different metals involved? So some implants might be more forgiving, some might not. So I would call up or write to the consultant and say, are there particular concern? Is it the weight? Is it the range of motion? Is there any other surgical factors? Sometimes what happens is it's more knee replacement is more complex for somebody who has a deficient ACL. So that could have been challenging fact. In those cases, they may not do. So it's having that conversation. It's not, in most surgical cases, it's not like a strict yes or no. It depends. So it's knowing those sort of variables and then addressing that. For example, some things can be changed, like knee flexion. Weight can be a factor, but sometimes the surgical implants might be different, or the type of surgery they do, whether it's a uni or a full or other comorbidities as well. So like with most things with the surgical, the general answer is case by case, and working with the surgeons and knowing their particular concerns. And if those concerns can be addressed by good rehabilitation, for example, just give you a quick example would be is running after a hip replacement. So the historical view is you can't run after hip replacements. The majority of my patients run because I work closely with those surgeons who allow the running, but some don't. So, and it's very difficult as a therapist to override that because I have to respect their surgical, expertise. So maybe the type of implant, the type of patient. So there's huge variations because it's just not the surgery, it's the implant, the patient selection, and also the confidence. So that's why I find spending some time with the surgeons whom send you referral and having a chat with them, then sort of clears that sort of ideas, and then they're a bit more open to those sort of things. So when I meet the hip surgeons, I tell them like I go through my criteria. So normally my patients return to running usually around 4 to 6 months, and then what are the criteria I use? And I write to them. It's the surgeons love to be updated on their progress step by step. So I send them regular updates on both the positive and the negative, and that creates a good relationship, and they're more likely to sort of be flexible in the demands. But definitely, it's very hard to override, especially when a surgeon has said no. I'll respect that, but I'll want to know what exactly was the reason for that specific advice.
Yes. Not only are you an expert clinician, editor, and writer, but you're also excel in diplomacy.
Yeah. I think one thing I've learned is giving that conflicting advice between a surgeon and a physio, it never ends well, you know. So if we're not on the same team and the surgeon says something and I say something and then the patient is confused and then it creates conflict. So I think right from the beginning, even before the surgery, I try to see the patients before the surgery and do a little bit of rehabilitation, and that's invaluable. So we know having a bit of pre-op rehabilitation, even if it's 2 to 3 weeks or 4 weeks before the surgery, sets people in the right frame of mind before the surgery. So have this, spend 3 4 weeks, have some rehabilitation, know what to expect. So it's well planned rather than being like a bit of a shock. So a lot of surgeons I work with send patients to me as pre-rehabilitation, where I see them before the surgery, educate them on the do's and don'ts, and then it's a bit more easier. So I find that sort of having that access and agreement with the surgeons on pre-rehabilitation is really important.
Absolutely, and appreciation of from the chat regarding your wisdom. Benoy, we are to the we are just over the hour mark, and I know you have patients awaiting on your schedule. Handspring has prepared a slide to show participants how they can get a generous discount on to order your book. So before we go to that slide, or do you have some closing comments, some closing remarks?
Yeah. So thank you so much for having me, and it's sort of nice to be able to sort of put it together and also give that sort of overview of the sort of the book. And and the good thing is we also have a free download sample. So if you go to Handspring, that which we can share on maybe on the chat, maybe somebody from the admin can share that, is you can download a free sample chapter, which is quite comprehensive. Have a look on that and see whether that is sort of style and things you want to explore before buying the full book. So we've given a quite a substantial amount of, I think there's at least 30 or 40 pages where we go through some of the tendon rehab. So have a look on that and see, is it something you would want to want to explore more, and then sort of gives you a sort of idea of what is in store for the rest of the book. So, but thank you all of you for giving up your time and joining us with Handspring. Thanks.
Thank you so much, Benoy. All the best. And now we'll take a look at the slide regarding the ordering of the book.
Yeah.
So we thank Benoy Mathew, one of the 3 editors of Hip and Knee Pain Disorders, Integrating Manual Therapy and Exercise. And from now until October 10th, Handspring is offering a 20% off the list price of the book. So you can get a lot of knowledge and a lot of substantial book when you use the code MTL, standing for Move to Learn 26, that's September 2609, MTL 2609 at checkout. And you can go to www.handspringpublishing.com, the hip and knee pain disorders. There's free shipping available in the USA and the UK. And just to advise you that this generous 20% off of the list price of the book will be good through October 10th. Thank you so much for joining us, and we look forward to continuing our substantial webinar series. So look for an announcement from Handspring Publishing regarding our next book and author. Thank you so much. Be well.